Okay. We would like to, good afternoon, first of all. We would like to welcome everyone to the first ever ELSA Outreach Program webinar series for 2021. As you all know, since the time of COVID, since last year, we've been giving a lot of webinars and services from the endoscopic laparoscopic surgeons of Asia. And if you've noticed, we've came up with a lot of programs like hybrid basic laparoscopic skill course or your BLSC, which is the one that we're taking right now. Part two will be the surgical video masterclass. And then part three would be the course, the live surgeries. Lectures and surgical videos will be given also. So welcome for this, the first ever hybrid basic laparoscopic skill course. This is the first part. The second part will be 2 weeks after this one. And the third part will either be the participants need to pass several procedures or do a hands-on, hybrid hands-on in your place. Like for Manila, we'll be doing a hands-on course in the Philippine Center for Advanced Surgery. We have several institute endorsed by ELSA. We have one in India, Mumbai, the Institute of Medical and Minimal Access Surgery, Chinese University of Hong Kong, Bali, Indonesia, one in Kuala Lumpur, Minimal Access Surgery Training Center in Hong Kong again, and of course the Minimal Invasive Surgical Center of David in Singapore in NUH, and one also in Vietnam in Ho Chi Minh City. So anyway, without much further ado, we would like to start off with the very first hybrid basic laparoscopic skills workshop. This is the first part, mind you, for all the participants. If you would want to get your certificate, you need to complete the three parts. Second part will be 2 weeks after the video masterclass with experts and test rate. Every every step, every part at the end of the lecture and after the end of the video masterclass, you have to take the poll and then you have the exam. So you need to finish everything, and then you'll be able to get the certificate. So the basic lab certificate will be awarded after the candidate passes the test from part one and part two, and at least 75% positive rate. For the part three, video showing his performance, or at least in a surgical task like pen transfer, suturing, or sugar stock, or you need to go to a training center accredited by ELSA, like Philippine Center for Advanced Surgery in Manila, or NUH in Singapore. Once you've done everything, you'll be able to get the certificate. Okay, so for today's workshop, for today's webinar, hybrid basic laparoscopic skill course, we have several lectures, all basic lectures from instrumentation, access, energy, endolaparoscopic suturing, anesthetic, and of course, the exit MCQ. Please take that exit MCQ. You won't complete part one without taking the MCQ. So without much further ado, let's go to the first part, which is the introduction on minimal invasive surgery to be given by Professor David Lumanto. I think Professor David Lumanto doesn't need any introduction. I think everyone knows him. So let's give it to Professor David Lumanto, a very good friend of mine. David?
Thank you, Alan, and welcome to everybody. We have quite a big number of participants today. We are grateful. As Alan explained very well, this hybrid course will be structured in three parts. And what I recommend you, when you get the registration link, please put your name, your email, your address, so we can trace and we can trace you, because when you're going to do the exam, the MCQ exit, your name will be stated there so we can check everything. The course will be first hybrid, but soon ELSA and ELSA OP with Alan, with Rakesh, with the Dr. Sujit, almost all the speakers, we have created the online courses. So you will be able to log in and do your course at your own pace and pass your evaluation test At the end, for example, of the basic course, they will be based on 9 courses. Let's move on with the basic principle in laparoscopic surgery, and I will have the pleasure to show you exactly how the course will be run online, and I will show my presentation with the pre-made course. Welcome, Sajid. Please let me know. Oh, sorry.
This course is structured in 6
Alan,
different
can you see?
modules, each accompanied with a McQ evaluation that will assess your knowledge and
Yeah, can, Prof, no problem.
Can.
The objective of the course is to understand the basic principles of endolaparoscopic surgery, laparoscopic instrumentations, energy sources, access to the abdomen, and how to avoid complications till the implications of anesthesia during laparoscopic surgery. Please drag the slider to discover the history. To begin with, laparoscopy simply means to look inside the abdomen using a scope or a camera. The abdomen is filled with gas, CO2, at acceptable pressure to help in laparoscopy. Please drag the slider to discover the history.
You can see a different age of development of laparoscopic surgery from Hippocrates, that was the first one to do, up to the Jacobeus that in the early 19th century, I think to cure the TB, was developing the first thoracoscopic rigid view. Subsequently, Verres developed the first Verres needle that you know today is utilized widely for create the pneumoperitoneum. And Harold Hopkins was responsible of inventing the telescope itself, using the famous rod lens. That is a big concave lens that magnify and transmit the view. In the 60s, Kurt Sam was actually the first surgeon, gynecologist that used an automatic insufflator. And Kurt Sam also was the first one, together with Mahet, to do the first abdominal procedure. Subsequently, the era of video laparoscopy today started in 1982 when the image was transmitted from the telescope through a monitor through a system of imaging. Then in the 1987, 3 people, Muyel, Mouret, and Perissat, did the first laparoscopic cholecystectomy.
Laparoscopy has come a long way since then. Its obvious advantages over open surgery has given it an edge in a number of procedures. It is even becoming the gold standard of treatment in certain conditions.
You can see today many procedures are done laparoscopic, especially benign. For malignant, it will come later on.
Here are the overall benefits of endolaparoscopic surgery compared to conventional open surgery. Those include less pain, faster recovery, and better cosmesis as showed for endoscopic sympathectomy. Newer innovations and technology has allowed the surgeons and the patients to benefit from it. Newer technology like HD monitors, 3D scopes, and robotics surgery is taking surgery into a whole new era of expansion. This has allowed the surgeon to actually keep their hands outside the abdomen of the patient. This decreases the contamination, source of infection, and quicker recovery, among other benefits. But there are certain challenges that needs to be addressed simultaneously. They can be grouped under general and specific. In laparoscopic surgery, the surgeon has to work in a 2D field, and since the surgeon has to look at the screen while operating, the surgeon should have a good hand-eye coordination. The surgeon also has a limited field of vision. There is loss of tactile feed as with open surgery. Other challenges includes problems with tissue approximation, maintaining hemostasis, and suturing. Laparoscopic surgery differs from open surgery in these aspects. As laparoscopic surgeons, You have to be able to learn all these technical aspects to become a better surgeon. This is not a fast process and takes time to adapt and apply the gathered knowledge in practice.
Especially because laparoscopic surgery is not like open. You work on a monitor, so you will have hand-eye coordination. You need to be ambidexterity. You need to look at the dissection and knotting and suturing in 2D and not in 3D. So these are the challenge of the challenge of the technique.
There are different technologies in the operating theater that you as a resident or a surgeon have to familiarize yourself with for a better understanding and output. The introduction of these technologies within the OR is not an independent endeavor but should be approached as a team which includes surgeons, assistants, operating theater nurse, anesthetics, and other helping staffs. As surgeons and assistants, you will have to learn and adjust to working in a narrow space, with longer instruments which are located at fixed positions on body surface, allowing only limited movements at its joints. There is a lot of practice that is required to master these skills as they have a steeper learning curve compared to open surgery. You will need more patience and more diligence apart from the setup to master them. So what is the solution to master the skills of laparoscopy? You as a trainer need to spend more time to train. You will need a more specific curriculum in your residency program. These skills needs to be broken down in multiple steps, which needs to be done in a more choreographed manner, which needs repetition and less perfected. And it is always recommended to have a mentor to guide you in this process to become a complete laparoscopic surgeon. Training is a vital aspect of learning in all fields and not just in surgery. Here we hope to be able to impart the knowledge to help you to become a competent and safe surgeon.
So it looks a bit strange to listen an online course, but I hope all the participants understand that we are in a way in an era of disruption, and probably online learning will become more popular. So this is just a few basic principles on laparoscopic surgery and challenge. I will pass the microphone to Sujit, that is the coordinator and chair of this course, to take over.
Thank you, David.
Oh, Alan, you're here.
Yeah. So let's go to the next lecture. Sujit.
Yeah.
Oh,
So the next lecture is about instrumentation and devices. So that will be Gafur. Gafur is one of our general surgeons and MIS surgeons from Malaysia. Gafur, over to you. Yeah.
Hi, Sujit. Thanks. Thank you so much, Sujit. Hi, everyone. Welcome to the first hybrid course organized by ELSA, and thank you for giving me an opportunity to present on this platform. It's very exciting to see this new way of teaching, and I think this will be the norm for a long time from now on. So as what Prof. David mentioned a while ago, we are using a platform where we have a standard way of lectures. So the standard set will be presented, and then any addition will be given by me. At the end of it also, I have a series, a set that I can also share with regards to more of my own personal views on instrumentation and what I think is important. So this will be the start of instrumentation and devices in endolaparoscopic surgery. So let me just move on here.
We can differentiate instruments in laparoscopic surgery according to their utilization. We will have three categories: devices to visualize the surgical field, devices to create and maintain the working space or domain, and instrumentations to perform the surgical procedure. To visualize the surgical field in laparoscopic surgery, we use the endolaparoscopic camera system. This will include monitor, camera control unit, insufflator, light source, energy device, among other additions.
I think it's very important that everyone knows how to manage the laparoscopic tower by themselves. Because when you are operating in different theaters, you have different towers to operate sometimes, and you cannot depend on the nurses. So I think laparoscopy has converted a lot of surgeons to become very technical in this, especially on which buttons to press, what type of tubing that's coming out of the machine. So you have to be very familiar with the technology and the tower that is available in your hospital. Okay, so you have different telescopes which you can use. You have the most common ones that we use are either the 10 millimeters or the 10 degrees, or the straight ones, or the 30 degrees telescopes. As you get more and more advanced, you prefer to use more angled telescopes. And also when you are actually dealing with areas within the deeper abdominal cavities or in the pelvis, you prefer a more angled telescope as well.
To work in an enclosed environment like the abdomen, telescope requires light. There are various light sources available. The common ones are xenon, mercury, and halogen. Today, xenon is widely utilized. Light is transmitted from the source to the scope through a fiber optic cable. The camera unit can be single or 3-chip, CCD, and they use the solid-state chip and the electronic retina. Resolution varied according to the technology, from standard definition to 4 or 8K definition.
Yeah, so many senior surgeons like Prof. Lomanto or even David would remember using single chip technology when it first came out. I feel that I have seen it once or twice, and I can relate to the challenges related to a single chip technology to what we have now. I remember the light bulb going off inside the laparoscope light source, and someone had to rectify it. And now you have got all this, which is now basically replaced by halogen and more advanced lighting systems. So this is a technology that is specific to the telescope, which is called the high definition endo eye. It gives you a more clearer picture, especially in relations to vessels.
To create the space in laparoscopic surgery with used CO2 insufflator. This are automatic device with high flow option for a fast gas replacement in case of suction. Intracavity pressure can be regulated at different grade. Carbon dioxide is widely utilized due to its advantages over others. Monitor can be in different size and resolution, standard versus HD or 4K. Lately, 3D camera system and monitor are in use for a better visualization that reduce the lack of depth that we have with 2D vision. Another group of devices and instruments are utilized to create and to maintain the surgical field or domain. These are the verse needle, trocars, and hand ports, among others. The verse needle is used to create the pneumoperitoneum using the eye-blind technique. Pneumoperitoneum can be also created using a so-called open access by inserting a dedicated trocar, called Husson trocar. In specific cases, an optical trocar, in which the telescope is inserted in, can also be used to enter the abdomen under closed visualization. Trocars are utilized to maintain the duomen or space and allow to insert instrumentation without leaking the gas. Trocar are made by an outer hollow cannula with a side port for gas and an inner trocar obturator that help for the insertion. A valve is inside the cannula and avoid the gas leaking during maneuver. The trocars are made of various shape, diameter, material. The inner trocar can have a cutting blade, a dilating tip, or be bladeless. The outer cannula can be smooth or have a grip or screw type for better position of surgical space to create a working domain. As an open conventional surgery, a large variety of instrumentations are available to perform procedures in endo-lap surgery. We have graspers, scissor, dissector, and more, and all these instruments differ for length, diameter, different jaw or tip, and design to accommodate various ergonomics. Most of the common instruments have a length that range from 30 to 45 centimeters, while the shaft diameter from 3 to 10 millimeters. The instruments can be rotated and have an insulated covering on their entire length to avoid inadvertent transmission of the energy.
So I think this is very important. You have got instruments that are of various sizes. So normally when you start off, you use 30 centimeter instruments. And as you go into more advanced procedures that may require more longer or more further reach, then you might have to use longer instruments, and a 45 centimeter comes into play. This is specific for bariatric surgery. You find that when you're operating high up in the hiatus and the fundus, you may need a longer instrument, but this takes time to gain familiarity. So only when you're familiar with the normal size instruments, the longer ones will make sense. Yeah. So you have got several graspers, dissectors, and I'm sure that in your relative OTs, you've got
Scissors are a
preferences.
key instrument for all surgeons. Straight or curved are ideal for a meticulous dissection. Sharp instruments should be always utilized under vision to avoid injury. Differently from open conventional surgery and laparoscopic surgery, due to the reduced number of trocars, other tricks are used for retraction of organs or structures. In addition to specific instruments, pneumoperitoneum provide helps, together with gravity, like tilting the operating table or the patients in different positions. There are special retractors that are created to help during laparoscopic surgery. For example, fan or coil retractors are available in different shapes to retract liver, spleen, lung, or intestine. For suturing, knotting, or tissue approximation, we can use different devices. Needle holders are utilized for intracorporeal suturing, while knot pusher are used for extracorporeal suturing. Needle holders are in different handling, jaw, and tips. However, suturing is an important skill to be acquired for laparoscopy. A separate module will discuss more details. Automatic suturing device like handostitch are also available to facilitate suturing. Needles and suture mate rails are also available in great variety to further assist in tissue approximation. There are pre-made ligature like the endo loops available. This because suturing is a challenging task in laparoscopy, and all these devices helps to reduce the needs and the fatigues. For tubular structures closure, clip applicators with single or multiple firing of staplers in different size. They are available in different diameter too. Last in tissue approximation are the staplers. Devices manufactured with a series of titanium staplers that allow the anastomosis of hollow organs. There are various stapling devices which can be used. Also of use are the extracorporeal knotting devices, which can save operating time. Other devices are the so-called fixation devices, utilized to hold prosthesis or others material in place. Special instrumentations dedicated to specific tasks are available. Pre-made or self-made bag to remove specimens. Forceps for tissue biopsy, or hollow clamp to allow the insertion of a catheter for intraoperative imaging like cholangiography. Suction interrogation device, or in addition with diathermy hook, are also available. The search for a better cosmesis and to reduce surgical trauma have developed smaller instrumentation and devices, like single port, that can accommodate the insertion of 2 to 3 instruments. To improve the ergonomics and the triangulation, some of the instruments are curved or articulated. There is always a debate if it is better to use reusable or disposable instruments. Similar if it is better to use metallic, plastic, or hybrid. Both have pros and cons to be considered, like safety, cleaning, cost, and recycling. From literature data, if we consider safety and care, disposable are better but are less green-friendly and more costly.
Okay, guys, let me just share another quick presentation regarding instrumentation that I've prepared on my own. Now, one aspect that wasn't focused during the presentation was the size of the operating theater. So I feel that it's very important, because I find that when I go and operate in other hospitals, especially in district hospitals, I find that there is a limitation and there is a difficulty in moving the laparoscope tower in and out of the room. And this is mainly because the OT is designed very small. So if you have a chance to, be in a center where you are in charge of setting up an OR for laparoscopy, you have to make sure that the size is enough. And the minimum dimension that you need is at least about 21 feet. If you have an OT of 25 feet, then you are in diameter, for example, in the maximum diameter, you have got the luxury of actually integrating the systems into the walls. So size is very important when you're talking about the OT. So these are the two OTs that I have visited that I find to be a bit of a contrast to each other. The one with the surgeon standing over here with the instruments is in Taiwan. I find that it is adequate because you have got just enough space for the lighting, for the towers and things like that. And this is the operating theater that I operated in China, the other picture. where you can see maybe about 10, 12 surgeons inside, and there's still a lot of space everywhere around. And this is too much space actually, which is not needed, I feel. Regarding the camera system and the light source, you have to understand that camera system is limited by the optical fiber technology and the light source. The clarity of the image may not actually depend on the technology. It is how well that you know how to use your camera, how well you know how to manage fogging, smoke, how well you know how to manage. For example, if the instrument requires cleaning, not too much cleaning, who cleans it and how it is done. And buying a basic system, basically you can achieve about 90% of day-to-day laparoscopic cases. For example, this is one of our trainers training a group of surgeons in sub-Saharan in Africa. And problem is always in terms of reliance. So when you get used to a higher technology, it is difficult for you to go back to older tech sometimes. So you have to be very careful when you are getting used to it. Now, these are the newer technologies that you have, especially with ICG and all. You can see vascularization more clearly, laparoscopically, even with the camera system. So this will improve your outcome in terms of doing an anastomosis and also predicting whether or not you can get a good anastomosis and whether this is going to leak. I think that this kind of technology is very important because during my time, this is very new now, and I feel that it will become the norm as we go along in the future. So these are the other types of technology that we have now, where conventionally you have to dissect and you have to see the cystic duct very clearly, but with ICG and retinal eyes now, you can see the structures even before you dissect. And these are the other examples needed. Now, you might need a lot of instrumentation, but I feel that these 6 would be the majority in most of your cases. You require either a varus needle, a disposable or reusable, trocars of varying sizes, 10, 5s, graspers, usually 2 atraumatic is the one that everyone likes to use, a Maryland fine dissector, a hook and scissors, a good needle holder, a good scissors, and a good suction device. And I can tell you that almost 80 to 90% of your surgical work can be accomplished by using only these. So having said that, it is not free of any complications. So this is one of my recent one that I had with a varus needle where there is a puncture in the middle sacral artery. So despite having good instruments, you must know how to use it. So not all the time having good instrument translates to good results. At the end of the day, it is the user uses it. And you need to be able to manage complications if they occur. Okay. So I think I've come to the end of my session. Back to you, Sujit. Thank you very much.
Yeah, thanks, Gafur. So thanks for using the poll. It's interesting. We have about 70% of our participants who are actually surgical residents, junior consultants, and postgraduate who are not in residency. So it's quite good. And experience-wise, there's about nearly 60% of them who have assisted less than 50 laparoscopic cases.
That's great.
Yeah, yeah, yeah. So so we'll proceed with the next speaker, which is Sajid. So Sajid is one of our MIS surgeons from Pakistan. He spent some time with us in Singapore under Prof. Lamanto. And Sajid is going to talk to you about access and complications. So over to you, Sajid.
You're on mute. We don't have a voice for you, Sajid.
Sajid, can you unmute yourself?
Can you hear me now?
Yes, perfect. Go ahead.
Thank you, Sajid.
Okay. So I'm going to talk about the access-related complication of the laparoscopic surgery. I prepared this module not for the whole of the complication of the laparoscopic surgery, but only for the access-related complications. The best way to predict your future is to create it. Abraham Lincoln once said. So MIS surgery is like a new future. It's a keyhole to the future for the general surgery. If we talk about the minimally invasive surgery, about the future, as Dr. Khafour told us about the equipment and the OR setup and in detail about what equipment should be used. But I think it's important to talk about the complications as well. What exactly is a complication in surgery? It's something which it is like a concurrence of the various causes and the conditions in the course of surgical procedure, which do not normally form a part of it, but which usually make it more serious. If we talk about the historical evolution during the evolution of the laparoscopic surgery, as Professor Lumanto was telling about the different phases of the evolution of the laparoscopic surgery, during 70s and the early 80s, that was the initial period when it was getting popular. It was basically the technical problem which was leading towards the complications. Late in 90s, when it was in the developmental phase, everyone was doing laparoscopic surgery for every procedure. So mainly the complications were due to the indications. But now when it is worldwide accepted, it's a surgical training, which is the people are not trained enough, which is causing these complications. Why complications occur? The mainly experience, yes. If you do 100 cases, the chances of getting a complication decreases fourfold. It's actually the learning curve. It's a learning curve is different for different procedure. Again, the complexity of the procedure. If the procedure is more complex, the chances of having a complication will increase to 9-fold. And then, of course, the comorbidities of the patient, like obesity and all other things. If the ASS score increases, so does the risk of the complications as well. So if we divide the complication of laparoscopic surgery, these are related to the position related, access related, due to pneumoperitoneum, during surgery, or the post-operative. But I'm specifically going to talk about the access related injuries. The common queries in the access related injuries are either we should go for a varus needle or a direct entry, umbilical port or a Palmer's point, metallic port or a newer port, correct entry, either my entry is correct or not, and the placement of the secondary port, where should I place my secondary port. Way of abdominal access is open technique like with Hassan, and the closed technique with the varus needle, trocar sheath, or the OptiView as well. We are talking about the safe entry. Safe entry means no injury to the abdominal wall vessels, superficial and the deep epigastric vessels, major vessels, as Dr. Khafour was showing one of the videos of the sacral artery, and the visceras as well, at the time of entry, injury to the bowel, bladder, and the other visceras. So why entry is so crucial? Why we are talking about this is a meta-analysis of 1.5 million laparoscopic cases published in 2002, and it is saying that more than 1/2 of the complications related to the laparoscopy are related to the entry techniques only. The incidence is 0.3 to 1% in this study. So if we talk about the entry-related injuries with the different technique, varus needle or the open technique, another analysis, another paper, which is showing that the vascular injuries and the open injury, the varus and the open technique, the varus needle carries a higher chances of injuries as compared to the open technique. So what are the universal steps for the safe entry to avoid the complication? These are the multiple steps, but I will try to emphasize more only on the 3 things: relaxed abdomen, empty stomach, and the empty bladder. You should emphasize more on these things, but also the other things are important, especially the anesthetized patient. If we talk about the anesthesia, which is causing, how the anesthesia can cause access-related complication, if there is an inadequate muscle relaxation, it would lead ultimately to contraction of the muscles during the port insertion, which will lead to difficulty in pneumoperitoneum and ultimately would cause the pain during the port insertion as well. So what should we do? So endotracheal intubation, let the pharmacological neuromuscular blockade complete, and there is a positive pressure ventilation, then go ahead for the your access technique. Another problem is the elevation of the abdominal wall during the varus needle insertion. So this study has proved that either you elevate the abdominal wall or not. It is recommended to not elevate the abdominal wall because it is not associated with any extra complications. Safety test, I will just omit this slide. So before going in, before accessing the abdomen, check all the gauges, your instruments and everything. Remember anatomy in your mind, a correct position of the needle, and then remember the BMI of the patient. Your needle should be at a proper angle. If the BMI is normal, then it's better to keep the your varus needle at an oblique angle. If the patient is overweight, you can decrease the angle to 30 degrees. And if the patient is obese, then it's better to go straight. Why is this so? Because the division of the aorta, I will show in the next slide, the division of the aorta in obese and in a thin lean patient is at although it's the angle is at L1, L2, T12 level, but even then, sorry, L4 level, but even then, the obesity and the abdominal wall structure make it different. I will show into the next slides. And then another is the, once you have inserted this varus needle, then the primary trocar insertion. Let the pneumoperitoneum to, up to more than 15 mmHg, because if you have not created a pneumoperitoneum, the chances of getting an access-related injury will be higher. If there is a more deeper space, like if you can see here, if the pressure is low and you will try to insert the trocar, the chances of injury to the bowel, even to the vasculature, will be higher. But it is much safer to go when the abdominal wall, when you have created a pneumoperitoneum below. So, and then secondary port. The secondary trocar insertion, apart from the ergonomics, it's very important to keep in mind the anatomy of the, especially the vascular anatomy. And remember, an inadvertent injury from a secondary port could be considered a negligence. It's when you are seeing from outside and inside, and even then you are injuring something. So for the secondary port especially, so it is considered as a negligence. So the first complication is a bleeding from the inferior epigastric artery during the access. The incidence of major vascular injuries occurred in 34 patients in 77,000 laparoscopic cholecystectomy. Let me share a video with you people. So, so we are trying to insert a secondary port, and here it's a boom. So deep inferior epigastric artery has injured, and every effort. So it's important to remember the anatomy where you are going to put your secondary port. So trying to hold it, coagulation it, but you know it's a like it's a systemic vessel, and any attempt to go with the coagulation will ultimately fail. And then try to do it again. No. So take your time. And then the best technique is either you can use this clip, or you can use the Phillips needle. But the best is to pass a transfacial suture to control the bleeding. Like if I can show you here. Yeah. Okay, so if this is a scenario, what to do? Diathermy, you have seen that it won't work, especially for the systemic vessels. Endocatch or Hemolog, probably if you have available with these clips. Deep suturing, yes, but if Foley's catheter, like for a pressure, you can use this one. But the best thing is suturing under direct vision. Then come the large vessel injuries. So we can prevent the large vessel injuries only by proper technique. So as I have shown you previously in obesity, in if the BMI is high or less, I will show into the next slide. So how can we recognize direct laparoscopic visualization, sudden drop of the blood pressure? In this slide, okay, here it is. So aorta is 0.4 centimeter above the umbilicus if the patient is normal weight. So the red is it's just for the show. The green is the angle which you must have. So if the BMI is high, like the BMI is up to 30 or 32, if the patient is overweight, not obese, then aorta is division of the aorta you can see at 2.4 centimeter above the level of umbilicus. So it's the green angle, you can see the angle of your varus needle. And if the patient is like obese, the BMI is higher, the division of aorta is 2.9 centimeter above the umbilicus. So it is safe to go vertically. So more obese is the patient, more vertical should be your varus needle. So the management for the large vessel injury is don't panic, leave this trocar in situ, seek and help from the vascular team, arrange for the blood, prepare for laparotomy and the vascular control, take a good vascular control on laparotomy. And then come the open or the close technique. If we talk about this open and the close technique, the risk with the close entry technique and the open entry technique, you can see the vascular injuries and the visceral injuries are almost equal. But the only problem is the failed entry with the close varus needle technique. So it's a 17 per 1,000 and 8 per 1,000 as compared with the open entry technique. And then if we talk about in close technique, even varus needle or a direct trocar entry, you can have a look that the vascular injuries is almost same. The solid organ injuries is almost same, but you can see the risk with the varus needle entry is 65 per 1,000 as compared with the direct trocar injuries. So the vascular injuries ultimately it contributes more into the access related complication as compared to the other injuries like injury to the viscera. And the mechanism, especially the varus needle or the trocar. And the bowel injuries, yes, it can also occur during the access, during the varus needle insertion, during the primary trocar insertion or the secondary trocar insertion. But mainly, there are the two mechanisms which are involved. One is a pneumoperitoneum, which you have not created, and another is the adhesions formation, which is which could be present even in the virgin abdomen. Let me show you this slide. Even if the virgin abdomen, 0 to 10% of the cases can have adhesion even in the virgin abdomen. But if there is the previous surgery, 75% of the cases may have this, you can predict that there is an adhesion. So the best is to go with the open technique. Even I won't say that the varus needle or the close entry technique is better. So best is to go with the open technique. So let me fast forward this video. So this is what I learned while staying in Singapore with Professor David Lumanto and Dr. Sujit. We always to go with the open technique instead of going with the varus or the trocar entry with the blind technique, which is the safest technique to avoid access related complication. So then take 2 sutures, hold the peritoneum, open it, use a sheath, and then pass it and control it. Alternative position to avoid the complication if you a patient had a previous surgery, the Palmer's point or the right lower quadrant point. Let me show another video of the left lobe of the injury, left lobe of the liver injured during the Palmer's point entry as well. So even if you are trying the left, the Palmer's point, better to have an idea through your through investigation, radiological investigation, which you have done to check the size of the left lobe. If it is coming because it's hanging on the way, and your Palmer's point entry can injure the left lobe of the liver as well. So there was an injury to the left lobe, and then we are trying to coagulate it and controlled it. So it's controlled here. So better be. And another axis is the optical trocar with or without the pneumoperitoneum. So this is what you can use into the obese patient when the varus needle, even the open technique would fail because there is a thick wall of the abdominal fat. So we are just crossing it, fat, then external oblique aponeurosis, crossing the external oblique muscle, posterior sheath, and here we go. This is the preperitoneal fat, and this is the peritoneal fat. Even the optical trocar can lead to a complication, like they can end up, you can't actually say that the optical trocar are also safe, because you can even end up into the adhesion or even into the intestine as well. So the rest of the complication, pneumoperitoneum surgery and the post-op complication, I won't go into the details. So the access-related injuries, it could be a visual perception illusions. And the best way to recognize your complication during the laparoscopic surgery is to show your work. Saying nothing, like they will blame the dog, is it won't work. So the best way to treat is to recognize it, and the best way to recognize the complication is to show it to the others instead of keeping it quiet. When you are seeing the complication won't actually work. And my take-home message would be, I'm sorry, I won't take longer. In order to operate fast, it is necessary to go slow, think twice, cut once, liberal use of energy devices, especially for whole of the laparoscopic surgery, and use the sharp ports if you have to. It's better to go with the open technique, but if you want to go with the closed techniques, then use the sharp ports. And thank you so much. You have completed this segment. Thank you so much.
Okay, thanks, Sajid. I think next we will move on to the anesthetic implications instead of the energy and OR safety. Lydia, you're there. So Lydia is one of our anesthetists who is working in NUH and Alexandra Hospital in Singapore. She will talk to you about anesthetic implications in laparoscopic surgery. Over to you, Lydia.
Hi, thank you. Can you hear me and see my screen?
Yes, can see your screen. Yeah.
Okay.
Can hear you also. Yeah.
Thank you. So the topic given to me is anesthetic implications in laparoscopic surgery. I'm just going to quickly talk about some of the physiological changes in laparoscopic surgery to start. So essentially, laparoscopic surgery requires the intentional generation of a pneumoperitoneum using insufflated carbon dioxide. And as the absolute volume of the air in the abdomen increases, the abdominal wall compliance will drop, and therefore the intra-abdominal pressure will go up. When this intra-abdominal pressure exceeds the physiological thresholds, the individual organ system will become compromised, and this can cause morbidity, especially in patients with multiple comorbidities. These changes are due to three reasons. The first is the systemic absorption of carbon dioxide. The second is the pneumoperitoneum itself causing a pressure effect within the abdominal cavity to rise. And the third is due to changes associated with positioning. Let me first talk about the systemic absorption of carbon dioxide. So the amount of carbon dioxide absorbed is directly proportional to the intra-abdominal pressure. Higher intra-abdominal pressure, more carbon dioxide absorbed, as well as the duration of surgery. Longer surgery, more carbon dioxide absorbed. This will therefore increase the partial pressure of carbon dioxide in the blood, resulting in a systemic hypercarbia. The systemic hypercarbia would then increase the amount of acid in the blood. So it causes the blood to become more acidic. And this has implications on enzyme function, causing things like myocardial depression, because the cardiac muscles become more acidic. And it can also affect metabolic reactions, such as those affecting coagulation, and it can cause a coagulopathy. The high carbon dioxide also can have direct effect on vessels, causing vasodilatation, as well as increased sympathetic nervous system response, like causing tachycardia and arrhythmias. This has profound effects, especially on like the central nervous system, especially and the cardiovascular system as well. So in the central nervous system, there can be an increase in cerebral blood flow, as well as an increase in intracranial pressure. This is exacerbated and worsened when the patient is in a head-down position. So in general, patients with an intracranial increase in intracranial pressure, like those with cerebral tumors, are actually not suitable to undergo laparoscopic surgery. We would usually prefer them to go for like an open surgery. Same thing in patients with very high intraocular pressure, like glaucoma. We'll also may advise these patients to go for open surgery instead. The next system I would like to talk about is the respiratory system. So the changes in the respiratory system is mostly due to an increase in intra-abdominal pressure. So when there's an increase in intra-abdominal pressure, the diaphragm gets pushed up, and this causes a reduction in lung volumes and an increase in airway pressure. So all these patients undergo laparoscopic surgery. Whatever airway device we use, they are paralyzed, and they are ventilated using positive pressure ventilation. If the diaphragm and the lung compliance is very poor, we would need to use very high amount of pressure to ventilate these patients, and these can cause barotrauma. This is especially a problem in the obese population who already are harder to ventilate in general, because already we need higher airway pressures to ventilate them. And when we need super high airway pressures to ventilate these patients, or we cannot ventilate these patients at all, we sometimes cannot even proceed for the surgery under laparoscopic technique. So there were a few patients in my experience that, especially really obese ones, they just couldn't tolerate the pneumoperitoneum, and we had to convert them to do open surgery. So other respiratory system changes include a reduced pulmonary compliance, uneven distribution of ventilation to the non-dependent part of the lung. That's the lower part of the lung. So the lower part of the lung usually is quite well perfused, but not as well ventilated. When there is a diaphragmatic movement to capillate, then sometimes there can be increase in atelectasis. This worsens what we call ventilation perfusion mismatch, because it causes some lung collapse or atelectasis in the lower part of the lung. This is worsened by hypercarbia, which is a high partial pressure of CO2, hypoxemia, which is a low partial pressure of oxygen, and worsen if there's airway and alveolar collapse, especially so in like the obese population. I would now like to talk a little bit about airway management as well as an aspiration risk. So there are two techniques that we use for airway management for laparoscopic surgery. Conventionally, we always intubate these patients, and that is the picture on the right. ETT is a definitive airway where an endotracheal tube is placed between the vocal cords. But increasingly, we have been using the laryngeal mask airway, and as the name suggests, it's actually kind of like a mask. It's oval shaped, and it fits just above the cords, with the tip of the mask sitting just above the esophagus, and the mask covers the piriform fossa. LME has been increasingly popular for multiple reasons. It's less invasive, faster to insert, very much better tolerated, technically easier with a lot less hemodynamic response. So it's generally preferred for the cardiac patients. And it's only used for very simple laparoscopic surgery, like maybe a lap hernia repair, where it's extraperitoneal sometimes. However, a laryngeal mask airway is not a definitive airway. So there is a risk of regurgitation of gastric contents and aspiration risk, especially in the head down position, especially when the IAPs are high and we need very high airway pressures to ventilate these patients. So sometimes when we put a laryngeal mask airway, when the patient is supine, we can ventilate them just fine. But once we start pneumoperitoneum, or especially when we put the patient's head down, very occasionally you will hear us telling you to stop surgery because we cannot ventilate the patient properly on the LME and we need to convert the patient to a tube. Regardless of whether we use the LMA or the ETT, usually these patients are paralyzed anyway, and usually they're on positive pressure ventilation anyway. But the ETT is also not without its problems. There can be problems with migration of ETT. It can move down and become one lung intubation. This is also exacerbated by the head down position. I'm going to move on to the cardiovascular system changes. So as the intra-abdominal pressure increases, there can be compression on the abdominal aorta, and this will increase the systemic vascular resistance. This is due to the RAS system activation, and just a quick reminder of medical school knowledge. Mean arterial pressure is total peripheral resistance times cardiac output. Cardiac output is stroke volume times heart rate, where stroke volume is dependent on preload, afterload, as well as contractility. When SVR increases, total peripheral resistance will increase, and this causes blood pressure to rise. When IAP increases, it also can compress the IVC, and this initially increases venous return because it pushes blood back into the heart. But later, as the intra-abdominal pressure increases even more, there is decreased venous return, and therefore cardiac output will decrease. This is exacerbated if the patient is hypovolemic, fasted for very long, or has like sepsis or shock or something like that. If there is a very high IAP, there is capillary displacement of the diaphragm, causing the intrathoracic pressure to go up, and this can reduce the blood flow back into the IVC because it's harder for blood to return back into the right atrium if the pressure inside the thorax is very high, and this can further decrease the cardiac output. So because stroke volume and venous pressure, venous return decreases, preload decreases, cardiac output decreases, and MEP will therefore fall. Okay, this also is balanced with what I talked about earlier, pain and hypercardia causing a sympathetic stimulation, which is a rise in heart rate. This can cause arrhythmias. If the acidosis is very severe, it can cause myocardial depression. So eventually, ultimately, whether the patient has a rise in blood pressure or a decrease in blood pressure as an effect of pneumoperitoneum really depends on the amount of IAP that is present, the intrinsic reserve of the patient, the volume status of the patient, and how good or bad the patient's heart is. In general, we say that if the IAP is less than 10, generally venous return should initially increase, blood pressure should technically go up. If the IAP is more than 20, usually it causes the inferior vena cava to be compressed. Generally, blood pressure will go down. So in humans, we do see a decrease in cardiac output with an IAP of 20 to 30 mmHg, and therefore we do recommend an IAP of about 12 to 14. Okay, let me talk about some more, a little bit more scary changes in the cardiovascular system that we see with pneumoperitoneum. The first is quite common, it's bradyarrhythmias. So this results from vagal stimulation from the peritoneal cavity. We recall that the gut is usually innervated by the vagus nerve up to 2/3 transverse colon. And the vagus nerve is actually part of the parasympathetic nervous system. When there is surgical stimulation on pneumoperitoneum around this area, the vagus nerve can be activated and there can be bradycardic response. Almost every patient, we would see some bradycardic response, but in the rare occasion, the bradycardic response is so severe that it leads to sinus arrest or complete AV block. So usually if this happens, we will recommend stopping the surgical stimulation, stopping pneumoperitoneum, and we will administer an anticholinergic drug like glycopyrrolate or atropine, something against vagolysis, a vagolytic agent. The steep Trendelenburg position is also associated with this thing called well-leg compartment syndrome. Essentially, what happens is that the lower limbs are raised above the level of the heart, so there is impaired arterial perfusion. Furthermore, there is compression of venous vessels by the leg supports, as well as decrease in venous femoral drainage because of the pneumoperitoneum. There's increased intra-abdominal pressure, harder for blood to return back to the into the IVC. This usually happens in longer surgeries, like more than 4 hours, patients with very muscular lower limbs, patients that are obese, or patients that have like peripheral vascular disease. So how do you identify them? Is that you will see patients with disproportional lower limb pain, patients have signs of rhabdomyolysis or myoglobin-associated renal failure. Another scary thing that we can see is this thing called CO2 embolism. That is what happens when CO2 is directly injected into the circulation. And this may happen during the creation of pneumoperitoneum, and again, it follows varying degrees, can occur in the beginning or later in surgery. We can see very scary things like cardiovascular collapse, cyanosis, increased venous pressure, pulmonary edema, arrhythmias, as well as decrease in end-tidal CO2. Essentially, symptoms are similar to any embolic phenomenon, like a pulmonary embolism or any obstructive kind of shock picture. But this follows a spectrum: small embolisms not so severe, larger embolisms more severe, and CO2 generally is quite soluble, so we do see them resolve after a while. Paradoxical embolism may also occur because there's an increase in right atrial pressure, and if the patient already has a PFO, this may open up and there may be an embolism right into the systemic circulation. The gas bubble can travel right up the carotid arteries into the brain and cause like a stroke. So the treatment is to stop insufflation. We position the patient head down and left lateral, hyperventilate the patient and try to aspirate the gas. But unfortunately, sometimes we don't identify these patients early enough to be able to place a IJCVP and aspirate the gas. Some other changes that we see because of the renal circulation are an increase in intra-abdominal pressure. So the blood flow to the liver and kidneys are compromised. In general, we see that the glomerular filtration rate decreases by about 25% with an IAP of 20 mmHg, and a persistent IAP of more than 20 mmHg can cause a reduction in mesenteric and gastrointestinal mucosal flow by up to 40%. With progressive tissue ischemia, so lactate will go up as the pressure increases. So patients with with already ongoing mesenteric ischemia, it may not be a very good idea to do a laparoscopic surgery. In view of time, I'm just going to skip over to some of the anesthetic implications. So in general, certain patients are not suitable for laparoscopic surgery, such as patients with severe IHD or pulmonary hypertension. Pulmonary hypertension is quite scary because any rise in CO2 can cause the pulmonary vascular resistance to go up quite significantly, and then there can be a higher PVR than SVR, and then there can be no cardiac output if that happens. End-stage respiratory illness, a raised ICP, patients with known cardiac shunts or PFO, and patients that are hemodynamically unstable. We also need to know that complications can happen fast and furious, such as embolic phenomenons, a bradycardia that progresses onto asystole, as well as pneumothorax or tension pneumothorax. Let me conclude by saying, by this quote that says, although laparoscopy offers advantages to both the patient and surgeon, it does involve considerable alteration in respiratory and cardiovascular hemostasis and should not be regarded as yet another minor investigation. So although we do understand that laparoscopic technique provides significant benefit to the patients, we do need to understand the physiology and potential complications so we can select our patients well and maintain their safety during the laparoscopic procedure. That's all I have to share. Thank you very much.
Okay, thanks, Vidya. We have, I think, 180 attendees, but only 95 voted. So those who haven't voted, please use the poll, especially for the MCQ. Rakesh, can we start with your lecture? Then maybe I'll finish off with the energy and safety in OR. Okay. So Rakesh is one of our MIS surgeons who is from Nepal. So Rakesh will be talking about laparoscopic suturing. Over to you, Rakesh.
Thank you. My slides are visible, Sujit?
Yes, we can hear you and slides are visible. You can put on full screen. Yeah, okay, yeah, perfect. Yeah.
So good evening, all of you. First, I would like to thank ELSA, OP, and especially Professor Lomanto and Professor Erlin for providing me the opportunity to present my work. So today I'm presenting the endolaparoscopic suturing, and I will be covering this in small title like introduction, a bit about ergonomics, instrumentation, what is the perfect istis, something about the knot classification, and more about intracorporeal knot and extracorporeal knot. So if we see why the laparoscopic surgeon are very reluctant to do the laparoscopic suturing, the few reasons which I found is a time taking. Sometimes, I mean, we have lack of confidence and we have interrupted practice for the suturing. We select improper knot type or improper technique of knotting. a difficult hand-eye coordinations, long cylindrical instruments, and two-dimensional vision and poor ergonomics. These are the things which leave the surgeon very reluctant about the laparoscopic suturing. So we need to set the perfect stage for our suturing in our OR. So there is a famous saying, quotes about by the Vincent Lombardi. He says the only perfect practice make the perfect things, and suturing is much more than tying a knot. So how we can achieve the perfect suturing? For that, we need to have a direct access to the target organ, optimal vision of operative field with the minimal loss of time and effort, decrease which can lead to decreased mental and muscular fatigue. We need to have enhanced recognition of structure and pathological condition, and we need to choose the right instrument and right suture. For this also we need a correct patient positioning, correct team and setup of our OR, table at its lowest or footrest if necessary, correct trocar placement, we will discuss that, constant relation between the eye and instruments and tissue, and we should maintain all the information which we need in our screen if possible. This is the surgeon operating in a very relaxed position. Why we need the relaxed position during the OR? Because if we operate in the long term, and as the surgeon getting older, if we are doing a laparoscopic surgery for 3 or 4 hours, I mean basically the suturing, and it can lead to cervical or backache or even the carpal tunnel syndrome or wrist pain. So if you can see in this picture, right side the perfect position and left side the elbow is less than 90 degree, and uh, screen is far behind, can lead to a very tiring surgery. Next about the trocar, there are, I mean, trocar position is different for the different surgery. But if we can see in this picture example of the lower pelvic surgery, we can for the suturing, if we place A is the for camera, B and C is for the suturing, is the contralateral port. It provides the best angle for best triangulation for our target organ, but ergonomics is poor. In this picture, if we can see, if we can place the port on the ipsilateral side, suppose we are working on the left side, then we can place the port on the right, or if you are working on the right, then we can put the our two working port on the left side. So it provides a very good ergonomics for the suturing. So these are the things we will discussing today. Is Yeah, suture, needle holder, and how we handle the instruments. So these are the different needle holder available in the different places. But what we need to understand is some are straight, some are curved. So straight one, what we say is the better because it provide a rotational movement of the. It's much more ergonomics because it provide a rotational movement of your wrist. Then different type of trocars are available: 5 mm, 10 mm, 12 mm, and it may be metallic, it may be silicone one. So silicone one with is better because it is a better ergonomics. You can easily remove and put your instrument directly without taking the holder. So it will lead to less gas leak. Less, and other thing we should note is the less the diameter of trocar, the more precision of your suturing and less tremor you felt during the surgery and suturing. Other factor when we consider the suturing or any sharp precision, the thickness of the abdominal wall, because more the thick, more you will feel the difficulty. And the telescope, what we should choose is the angulated telescope, which is either 30 or 45. 30 is better because we need to see in the every corner or every part of our stitch. And another thing we need to consider when we put a suture is we should pass the needle the perpendicular to longitudinal axis of our surgical wounds. We will see in the videos. Another thing we should consider when putting our port is something about the ergonomics of port and camera. We should consider these three angles. First is the azimuth angle, is the angle between the camera and the working port. It should be 30 or between 22 to 37. If you reduce this angle, you will have much more difficulty in suturing. Another angle is manipulation angle, which is the angle between the two working instrument. If you increase that angle, you will have a very difficulty in suturing, or if you put a very close angle, then again you will have a difficulty. Next angle is elevation angle, is the angle between the patient body wall, abdominal wall, and your working trocar. So it should act like a type 1 lever. If you, it should be around 60 degree. If you reduce the angle, reduce or increase the angle, you will have difficulty in doing the laparoscopic work and can increase the trauma of the intra-abdominal organ. Other thing we should consider when we are working in the very close space, like our instrument should not fight what we call dwelling shot phenomena, and our camera should be focusing toward our the target organ. If, because if we work against the camera, it can produce a blind spot. And we should try to work with the our like if some surgeon is right-handed, then he should try and learn to work with the left hand also. It called ambidextrity. It will help in the precise suturing also. So when we suture any target area, so we should imagine a circle. We should create an imaginary circle around the target organ, and we should always keep our instrument between this target or this circle, and we should draw a line. Upper part of which should be clean, like we can see in this picture. We have drawn, this is the target organ suturing. This is the imaginary circle, this is the horizontal line, and we can see the upper area is quite clean. Then we should in this imaginary circle, there should be only one part of the thread, because in the left side we can see too many threads. It can lead to difficulty is struggling during the suturing. Like in this picture also we can see a lot of suture, so it should not be like this. It should be only one suture, and we should try to keep other part of the suture outside this circle. We will see in the video also. And next thing is how we should insert and remove the needle, loading technique and advancing the needle. So we have different size of the needle: half circle, 3/8, 1/4, or curved needle or straight needle. But most commonly we use is the half circle or the half curved needle. It can be introduced, is very easily introduced through the 10 or 12 mm trocar. Then this is the very short about the part of the needle. It's a point, body, and wedge. So how we should introduce the needle? So 10 mm, with the 10 mm trocar, we should hold near about 2 to 3 centimeter the suture of the our what we pass inside. Then we can open the trocar side, or with the 10 mm it should not be difficult, and we should introduce through that. Then how we should load the needle? There are three techniques of loading the needle into the needle holder. One is hanging grasp and pull technique. We can see in this picture. In this, we should pick the tail of the suture, and by pirouetting the needle, then with the right hand, we should hold the needle, and when it's aligned, we should lock our needle holder. Next is lay down, lay down and pick up technique. Is a very simple technique. We should position our needle onto a safe or flat surface like stomach or small bowel or even the liver. Then with our right hand or with our needle holder, we should press towards the tissue, grasp the needle with progressive strength till it aligns, and then we should lock it. Then last one is alignment technique. we should hold the in this we should hold the needle end of the needle. Then with the left hand we can rotate our suture, and when the needle is ending, we should lock our needle holder. Then how to pass through tissue? Uh, we should hold the needle and pass perpendicular to the incision, what we call a theory of parallelism. If we considered in this blue line is the vertical axis, I mean the vertical axis of the wound, then we should p axis is the rotatory axis of needle holder, T plane is plane of our needle holder, and it should be passed perpendicularly. Then there are different types of knot. Intracorporeal is the square knot, surgeon knot, or slip knot. We will see in video. Then extracorporeal, we have knot. We should have they're about a full length suture. Should have a knot pusher, and we use mostly the half stitch. Another example of extracorporeal knot is Rodder's knot, Melger's knot, or pre-made Indio loop available. So intracorporeal knot, I mean, when we will see in this video how we make a surgeon's knot. So this is the needle inside the body cavity. Then the needle is already loaded in the needle holder. It should pass to the vertical right angle, 90 degree. With the left hand, the tip upward, tip should not be downward, tip should be upward. Then we should pull through the left hand, and we should with the right hand we should guard the tissue with the tip down. Tip should be like downward. Then we should pull. So we can see if we drop the needle, there is already formation of a C loop. What we need is the C loop. So moment we drop the needle, we will have a C loop formation, and tail should not be more than 2 centimeters, because longer you keep the tail, more will be the difficulty. Then left hand is static, right hand we just rotate, half rotation, then one hitch, two hitch, then we should catch the tail, push toward the opposite direction, and all the left hand should be static. All the movement should be done by the right hand. We should not pull the tail, because the moment we pull the tail, it will lock. Then if we again drop the needle, this is the reverse C loop. Again we rotate our right wrist slightly and catch the tail. And we should not pull towards upward. It should be in the straight plane. Then again a C loop formation, and is the last knot. So 2 1 1 is the surgeon's knot, and all the movement should be done by the right hand. Left hand is static here. So next we will see the slip knot. Slip knot is necessary when there is a tension between the two edges. So we pass the perpendicular to the incision. Should guard the tissue. Again onto the contralateral side, opposite side. So here the tail should be more than up to 4 to 6 centimeters. because we need to oppose the tissue which are in quite gap. So again, tail is longer here than 2 centimeter. So moment we drop the needle, we will have a C loop formation, a slight wrist rotation, one loop. So here we should form only one loop. Then this should not be tight and should be kept on not on the left side. It should be kept on the right side because we need to oppose these two structure. Should be kept on the right side. Then next loop is made by the reverse C. I'm sorry for the poor quality. The tail is catch here. Then we slide the knot. Is also called the tumbling knot, tumbling square knot. Now you can see the sliding of the knot. It's not too tight. You can see the sliding. Now it's tight. So you can see the two surfaces which are slightly far can be opposed with this technique, which is difficult with the surgeon's knot. Rest two wind should be completed. So again, it's a 2-1-1, but longer tail and slipping knot. The next one is the continuous suturing. It's also important in the bowel or peritoneum when we do the hernia surgery. So in this, we can see the passing of the needle through the tissue.
Rakesh? Yeah. Are there more slides left?
Yeah. Oh. Okay, so we will see in the next video. So in this, we can see the live, the patient suturing of the crura of the diaphragm for the hiatal hernia surgery. So again, this is the ethibond suture passed through the left crura. Perpendicular, and this is the right crura. Then again, surgeon's knots are formed with two loops. The suture should not have any memory, because if we have suture with the memory, we will have a struggling during the surgery. So this is the formation of knot, surgeon's knot. Next, we have into this suture, which is barb suture. It's very easy. We don't have to make a knot. So we can see in this video, after gastrojejunostomy, the introtomy is closed with the barb suture. So there is already formed loop. The moment you pass the suture through this, it will be locked, and barb will hold the tissue into the position. So what you need to do is just pull pull the suture, and it's already locked. No need, I mean, in this way, we don't have to put any knots. Then we have next what we can make in the is the extra. These are the intracorporeal, and next is the extracorporeal knot, for which we need to have a long suture, either 75 to 90 centimeter. We should have knot pusher. And one example of this is the Roder's knot. We can see in this picture, one with the long suture. We catch the suture and we make a half knot, then 3 rotation, and then again a half knot, and we can use it into the as a Indo loop. A pre-made Indo loop is also available. You can see in this for the appendicitis, after the ligation of mesoappendix, the Indo loop is applied, which is basically a Roder's knot. It can be applied for different. So this is my last slide. The take home message is learning to sutures require special attention to the setup, visual perception, hand-eye coordination, and motor skill. For that, we need to do a practice, practice, and practice. Thank you.
Okay, thanks, Rakesh. I will continue with the energy and NOR. There's, I think, 2 lectures, but I will only concentrate on the important slides. So anyway, this content is available online if anybody needs to look. Are you all able to see my slides?
Yes.
Yes, we can see.
Yeah. Okay. So basically, I'll be talking to you about monopolar, bipolar, and then other alternative energy sources like ultrasonic, high frequency bipolar, and then some safety concerns. I don't think this is needed, so we all know this. Yeah, so there's a difference between cautery and electrosurgery. Cautery, there is no current involved, and electrosurgery, there's current which is involved, and it involves the patient's body. Effects of heat. So it's quite obvious that we all know that irreversible damage to the proteins and cell happens beyond 60 degrees and so on. Yeah. So important slide. So monopolar and bipolar, what's the difference? In monopolar diatomy, what happens is, as you can see in this particular slide, that the electrosurgical unit generates the electrical current that we need to work on. It goes through an active electrode, goes through the patient, and then comes back into the machine to complete the circuit through a dispersive electrode. Dispersive electrode is a diatomy pad that we, in our usual terms. Monopolar, the entire patient is not involved. The current only travels between the 2 electrodes inside within our bipolar faucet that we use. So I mentioned about this. I will skip this. Okay, so this is an important slide again. What do we mean by our late term cut and coax? So in the electrosurgical unit, there's a thing called duty cycle. So in this duty cycle, what happens is during a cut, the machine works continuously and it uses a high current with low voltage. Okay, and you have on the other side, you have the coax, and in the coax, the machine works less. Okay, and it involves low current and high voltage. Then we also have these blended forms. So you can blend according to the activity that you need to be done on tissue level. If you need more cut, then you use a blend 1 form with the machine is more active, and you use blend 3 if you don't need a good vaporization or cut. So use like a blend 3 form. Yeah. So yeah, I mentioned this utility. Okay, so few characteristics of how we use this electrosurgical unit. And one is cut and vaporization. So as I mentioned in my earlier slide, which is this one, the cut uses a high current, low voltage, and the machine works 100% of the time. On the other hand, desiccation fulguration, we use more sort of a coag, but the machine actually functions not so much as the cut. And the difference between desiccation and fulguration is basically the fulguration, we don't touch the patient's tissue with the diatomic pencil. Okay, we use it slightly away, so let superficial coagulation happen. Okay, next. So I mentioned this already. Okay, what happens is bipolar, I already mentioned. So the current does not travel the entire patient's body. The current only travels between the two electrodes. Safety consideration. So what are the safety considerations when it comes to laparoscopic surgery? So if you think about the entire circuit, okay, errors and issues can happen at any of this stage. Okay, it can happen at the dispersive electrode or the diatomic pad site. There can be application site issues if there are hair, if there is wet, if there is any alcohol solution, if there's any water or anything in between the patient and the dispersive electrode, it doesn't work. Number one, because the current diatomic machines or electrosurgical units are able to pick up these kind of signs. If not, there can be burns. So there can be partial detachment, and due to that, there can be thermal injuries to the patient, or a patient can get electrocuted. Active electrode injury, there can be an inadvertent activation of the active electrode, and there can be direct extension from the active electrode into the surrounding sites. If you use very high energy level, if you use more than 50, 60 watts in the electrosurgical unit, there can be risk of injury to surrounding tissue. Current diversion is a known problem. Insulation failure. So currently we do have some machines in most of the hospitals to check insulation. Direct coupling is what we usually use, to stop a small bleeding, we use with a forceps, and then we ask our assistant to touch with a coagulation in the diatomic pencil. The next two, I will explain to you with the images next. Yeah, so direct coupling is basically, it can happen when a metal object comes into contact, usually inadvertently, when we use the diatomy with the active electrode. Same thing, so this is an example on the image below. Insulation failure, I already mentioned. So what can happen is our laparoscopic 5 mm instruments, or even 10 mm, whatever, these instruments are actually insulated. So once the insulation is damaged, current can leak out, especially if you're using a metal trocar. This can be quite dangerous because you don't even know where is the metal trocar is touching. So insulation failure needs to be taken seriously and needs to be checked. So most of the time, when they prepare the instrumentation, they also check for insulation failure. Capacity coupling, what is capacity coupling? Basically, it's a current that builds up between two conductors, which is separated by an insulator. So the insulation can act as a capacitor. So when can this happen? Especially if you use high energy, and if you use or metal trocars, so the the insulation in the instrument can act as a capacitor, and the current will build between these two conductors, and then once it touches organ or even bowel, it can get discharged. Especially this can be dangerous if you activate your active electrode freely without touching an object or an organ, where the circuit doesn't get completed. And if you use high energy in the diatomy setting, if you use a high diatomy setting, this can be dangerous because the stored charge can be higher. So longer instruments, thinner insulation, higher voltage, narrow trocars, open circuit activation are risk factors that can cause capacitor coupling. Okay, new generation of energy sources. These are basically ultrasonic to high frequency bipolar to combine energy sources. So I'm sure most of you have heard of some of these instruments. Harmonic is basically an ultrasonic device. What happens in the harmonic is electrical energy converts into mechanical energy, and this mechanical energy is what achieves the effects on tissues. So there's an oscillating saw. The oscillating saw actually vibrates about 55,000 times per second, and then you can change the length of this oscillating saw, and the length then decides on what's the tissue effect that can be achieved. So using ultrasonic device, you can do a coaptation, coagulation, cutting, and cavitation. These are the actions that you can achieve on tissue level. Coaptation is closing a vessel. Coagulation, you know. Cutting, you know. Cavitation is basically, if you just use the vibrating saw, it can cause cavitation on tissues. So this is what I mentioned. There is oscillating saw, and that's where that's the vibrating saw. You increase the length at the maximum length. Basically, you can transmit more mechanical energy. Is more efficient in cutting. Minimum length, which means the length is lower, so you can achieve a good hemostasis rather than cutting. Ligature or high frequency bipolar. So what happens is instead of our usual bipolar, this machine is capable of detecting tissue impedance at least 200 times per second. So the machine is more intelligent that it will decide how much energy to deliver at tissue level. So the other advantage of bipolar is the lateral thermal spread is much less compared to a ultrasonic device. So we have new techniques now. Actually, it's not new, it's quite old now. It's been more than 5 to 7 years already. So the Thunderbit is a device that uses both ultrasonic as well as high frequency bipolar. So both the mechanisms are combined in this. I won't go into detail because I think we are a bit short of time. You can look into the online course for further details if need. This is important. So what can they achieve? So vessel sealing can achieve up to 7 mm. The harmonic now has an ACE+7, which can achieve about 7 mm. Cutting speed are nearly equal. Ligature doesn't have, or the high frequency bipolar doesn't have a cutting mechanism. Using electrical energy, it relies on a mechanical blade to cut. And otherwise, they're quite efficient. It makes surgery faster, but as a surgeon, you need to decide whether you want to use all these devices and then seal a 7 mm vessel, which can eventually bleed, or 8 mm vessel, which will eventually bleed. So we need to use our instincts and what we have learned. So safety is first. RFA microwave ablation. So RFA mainly used for solid tumors to actually burn them. So radio frequency uses a frequency of up to 375 to 480 kilohertz. And this basically similar to our monopolar circuit. And because it uses quite high energy, you need a lot of, at least 3 or 4 dispersive electrodes to get the current back into the system. Microwave ablation works with electromagnetic waves. It's about 915 to 9.2 gigahertz, 915 megahertz to 9.2 gigahertz. And then it basically uses electromagnetic waves to achieve the tissue effect on the tissues. Next is surgical smoke. I think most of you know that this is hazardous, and then it needs to be, it's one of the more hazardous things compared to cigarette smoking. So it can cause cancers, it can cause other effects. So best thing is to avoid surgical smoke. How it's done? from infrastructure of OT and the instruments you use, from the energy you use, is very important. And we have smoke evacuators now, especially in the era of COVID-19. So this is important, and the smoke evacuators that use ultra low particulate filters or ULPA filters are quite effective in evacuating surgical smoke together with harmful viruses and etc. I'm rushing, I'm sorry, but I think I will stress on the important things. So how to reduce use an operating room with positive pressure ventilation, we call it the HEPA filters, and avoid gas leakage around the trocars by minimizing the wound incision. So use adequate wound incision. I mentioned about the ULPA filtration. You can use smoke evacuators to evacuate the gas after your surgery is done, not just evacuating the gas by opening up the pores. Again, this is quite important, surgical energy and safety in OR. So fire is a triangle. So you need to have an ignition source, which is us usually. The surgeon, lighting machines, energy devices. You have the oxidizer, which the anesthetist will provide us. Then you need the fuel. So fuel can be anything from surgical drapes and could be alcohol wipes that we use, or anything around can burn. So it's important that you know what are the ignition sources, which is listed here. You know that what are the fuel and what is oxidized, nitrogen oxide and oxygen. So when you know, please avoid these things. During the timeout, it's very important to make sure that no alcohol-based solutions are used, because they're quite inflammable. And then take care on how you operate and what you do with your energy devices. What happens, what to do if there's a fire in the airway? So disconnect and remove the tracheal tube together with your anesthetist. So please coordinate with them. Discontinue the flow of gases at least until the airway fire is settled. Can use saline and ventilate via mask and re-intubate once the situation is settled. And always need to perform a bronchoscopy to make sure that the airway is not further damaged, and to inspect the airway to make sure no further damage is done. Fire in the OT. So nearly all hospitals and all OTs should have a fire evacuation drill, or a place that they need to evacuate the patients during a fire. And so don't panic and control the airway, control the fire by using the acceptable methods. So there's different type of fire extinguishers available, which I will not go into detail. And stick to your hospital protocols in terms of managing fires, in terms of larger fires. I think that's all I got. Ellen, I will leave it to you for the MCQ.
Okay.
I will stop sharing. I think next is the MCQ.
Yes, let's put up the MCQ.